Our RHEIA trial, a randomized research trial in women with aortic stenosis, has already been running since 2020 in 12 European countries. We have asked now a couple of key opinion leaders to share with us their thoughts on the trial and its challenges concerning patient recruitment.
For me, the RHEIA trial is a very important study, since it's the first trial investigating female patients with aortic stenosis and low surgical risk.
The RHEIA trial is a really important question, firstly because it's the first randomized trial for low-risk patients in Europe compared to the partner trial in the US. And secondly, myself being a woman and an interventional cardiologist, I think this trial will answer a really important question in the female population with severe symptomatic aortic valve stenosis.
TAVR has been well validated for men across all surgical risk. However, women were largely underrepresented in the low-risk trial comparing TAVR versus SAVR. And the RHEIA trial is unique and the first and only trial that compared TAVR versus SAVR in women, with especially with low surgical risk.
In our center, we basically screen all the patients who we see with aortic stenosis as potential candidates for the RHEIA trial. So when they are female patients and older than 65, they undergo CT scan, and when they are eligible for the trial, we try to include them.
According to the new European guidelines, the patients with symptomatic severe aortic stenosis are being discussed in the heart team, and we are trying to reach in the first place to the referring physicians in order to tell them not to influence the patient before the patient comes in our tertiary center where we perform the operation, rather either TAVR or surgical treatment. And then we see the patient in our center and discuss within the heart team what is the best treatment option.
I think we should use whole pipelines. The clinical echo base is often useful to identify the patient upstream of the indication of intervention. The outpatient clinic, the heart valve clinic, if you have heart valve clinic in your center, look after these heart valve clinics, and the heart team. Especially all the patients who are referred to your institution with an indication of AVR, even if it's an indication of SAVR or TAVR, these patients are evaluated by the heart team, and they may be eligible for both intervention.
We are discussing openly within the heart team with the patients which are the treatment option. Per default, now the treatment in low-risk patients, males and females, will be a surgical option. With the RHEIA trial in female patients, we have the option through randomization to also have TAVI in this population, and ask the important question about which is the best treatment for this category.
We should present that both options, in their case, both options, a transfemoral TAVR or a SAVR, are considered according to guidelines and good practice, two very good options.
It's very important to go there as a team, the cardiologist and the cardiac surgeon. We explain exactly the purpose of the study and what the options are for the individual patient, and so we are able to enroll most of the patients we are actually asking to participate.